Even though this echo is run out of the Tennessee Department of Health, we really want this to be community-driven. So today's agenda will include introductions and announcements, a didactic presentation by Dr. Cody Chastain that will highlight screening of hepatitis C virus in adults and pediatric populations, 2 case presentations with time for Q&A for each, and closing remarks. So before we jump into introductions for our hub team, a few quick reminders I want to highlight that you may have seen when you joined the session. Next slide, please.
Hey, Lindsay, can we hold on 1 second? Sorry, it looks like there's an automatic timer going on with the presentation. Let me just shut that off real quick.
Sure.
Not sure how that occurred. Okay. That's why the slides were looking all crazy. Apologies.
No worries. Shamia, in the meantime, could you put the link in the chat for the sign-in sheet that we'll need everybody to fill out? So if everyone could please fill out the sign-in sheet. We need this for our accreditation. And also if you want continuing education, we'll definitely have to have you fill this out. Okay. So this is the lovely sign-in sheet. So if everyone could please, you can click on the QR code. Shamia will put it in the chat. But I really need everybody to fill out that sign-in sheet right now, please. And we'll give it just a minute. This also includes our subject matter experts and our TDH team. Everyone needs to complete it. And if someone can start giving thumbs up whenever you've completed it, we'll know that we've given enough time.
And Lindsay, we should be all set now, so apologies.
No worries. Okay, I saw 1 thumbs up, but we'll give it a little longer. So remember, everybody needs to complete this. Hub team, participants, everybody, please. Even if you don't want CE, we need you to complete this. All right, another thumbs up, great. I'm gonna give it about 1 more minute. Okay, so please continue to work on that if you need more time, but we're going to move on. So now a few disclaimers, reminders, and requests. Next slide. So the Tennessee Department of Health Hepatitis C virus Project Echo sessions are intended for prescribers treating or interested in treating hepatitis C and their clinical staff. Next slide. Please turn on your video and mute yourself unless speaking. If you would like to ask a question at any time, please use the raise hand function and Shamia will call on you. And you can also ask questions anonymously by sending a private chat to Shamia. All sessions will be recorded and sessions will be available on YouTube within a week. You can find these recordings by visiting our website. The link and the QR code are on the right side of the screen and clicking on the View Past Session Recordings red button. Shamia will also put this link in the chat. If everyone could please take a moment to rename yourself in Zoom with your first and last name. And if you need assistance in doing this, or if you're having any Zoom tech issues throughout the session, please private chat Anastasia for assistance. Anastasia, has anyone joined by phone?
Not that I see.
Great, thank you. Next slide. So please never discuss PHI and please treat everyone with respect. Next slide. And finally, you must be present for the entire session and complete a short evaluation survey within the next 48 hours to be eligible for the full 1 hour CE. The evaluation survey will be emailed to you post-session. And after the evaluation survey is completed, a link to download your CE certificate will also be emailed to you. And please note at the bottom, there's 1 additional step for pharmacists within the evaluation survey. Okay. So with that, let's launch. So we've brought together several subject matter experts, or SMEs, with adult hepatitis C, pediatric hepatitis C, and pharmacy expertise to discuss case presentations submitted by you. A didactic topic will be presented at each session by either an SME, Tennessee Department of Health staff, or a requested speaker. And topics have been established for the first several sessions and can be found on our website, which Shamia will put in the chat. We will also discuss up to 3 case presentations at each session, inclusive of both adults and pediatric cases. So with that being said, I would first like to introduce our SMEs and have them come off mute and introduce themselves, actually. So first up, our adult hepatitis C SME, Dr. Chastain.
Hey everybody, my name is Cody Chastain. I'm an assistant professor of medicine at Vanderbilt University Medical Center in Nashville, Tennessee. I am both an HIV and viral hepatitis infectious disease specialist, and I also serve as the principal investigator for the Southeast AIDS and Education Training Center. So thanks so much for having me.
Thank you, Dr. Chastain. Next up, our pediatric hepatitis C SME, Dr. Alfaro Cruz.
Good afternoon, everyone. My name is Ligia Alfaro Cruz. I am currently an assistant professor of pediatrics at East Tennessee University. I am located in Johnson City, and I usually take care of pediatric patients in gastroenterology, hepatology, and nutrition.
Thank you. And finally, our pharmacy SME, Dr. Clark Allen.
Hello, my name is Clark Allen. I'm a pharmacist at Regional One Health Hospital in Memphis, Tennessee. I completed residency here at Regional One Health and then transitioned into a role in the specialty pharmacy. My primary roles are in the hepatitis C clinic, where I see patients in the hepatitis C clinic, as well as the HIV clinic, as well as the GI clinic. So I see patients in all 3 capacities, and then also pregnant population will be transferred into the general hepatitis C clinic. So I'll see patients, all adults, in those clinic settings.
Thank you. So now I'd like to introduce you to our Tennessee Department of Health staff. We will be present at each session and keep things running smoothly, hopefully. And we're here to support you before, during, and after each session. So as mentioned, I'm Lindsay Sizemore. I'm the Viral Hepatitis Program Director. So next up, we have Dr. Talley.
Hi, Pam Talley. I'm the Medical Director with oversight for HIV, STIs, and viral hepatitis here at the Tennessee Department of Health.
Thanks, Dr. Talley. Shamia.
Hi, I'm Shamia, or Mia. I'm a registered nurse at the Tennessee Department of Health and serve as our Director of Viral Hepatitis Prevention and Clinical Services.
Thanks, Shamia. In case you're wondering, we did not coordinate our outfits today at all. A total surprise. Heather, you're up next.
Hi, I am Heather Wingate, and I am the Director of Viral Hepatitis Special Projects and Epidemiologist on the Viral Hepatitis team.
Thanks, Heather. Melissa?
Hi, everybody. My name is Melissa Moon. I'm an RN, and I'm the Viral Hepatitis Community Outreach Coordinator.
Thanks, Melissa. Laura?
Hello, my name is Laura Price. I'm a registered nurse, and I'm the perinatal hepatitis C coordinator for the state of Tennessee.
Thanks, Laura. And Anastasia?
Hi, I'm Anastasia Kihigel. I'm the CDC Public Health Associate, and I work across HIV prevention and viral hepatitis prevention.
Thank you. So you can view the detailed bios of everyone who just introduced themselves, SMEs and TDH team alike, on our website, which Shamia will put in the chat. And so with that, I'm going to turn it over to Dr. Chastain to provide our didactic presentation for today. Dr. Chastain, please say next slide when you're ready for us to advance, and we'll turn it over to you.
Sounds great. Thank you so much, Lindsay. And I wanted to welcome everyone who is participating today, regardless of your role. It's an honor to be part of the Tennessee Department of Health Project ECHO program. And I know I speak for my subject matter expert colleagues who we are all very enthusiastic for supporting this type of work, and really appreciate the opportunity to get to know all of you in whatever setting you're working in. I think one of the great opportunities within this ECHO program is not just for education and didactics, but also to try to link people working in different settings who all have something to offer as we try to better care for populations in our regions. To kick off our didactic series, we're going to start at the very basic, which is screening. The initial care of people with hepatitis C starts with making an appropriate diagnosis. And so understanding screening, both in adults and special populations, including both pregnant persons as well as pediatric populations, is really incredibly important. As we work through this didactic series together, we're going to build from the ground up as try to bring you all along with us from everything from screening and diagnosis to initial evaluation to treatment selection and subsequent care. But no matter what cases you have, we are going to be open for those discussions regardless of what the didactic series presents. Next slide. So I will say I have no financial disclosures or conflicts of interest to report related to this project. I did mention I serve as the principal investigator for the Southeast AIDS Education and Training Center, and we were happy to support the Tennessee Department of Health in this work. We are federally funded at the Southeast AIDS Education and Training Center, and I'm able to do this in part to deliver education related to comorbid conditions that can affect people with HIV, including things like viral hepatitis. If you need additional assistance, we can also provide additional education, whether it be in space of HIV or other aspects. But I really encourage you to partner with Project ECHO team, with Lindsay, with Mia, and others to figure out what your needs are in this space. And if we can do additional education or collaboration with you, we are happy to support. Next slide. So let's start at the very basic ground floor as far as diagnosis. What is the approach to making a diagnosis of hepatitis C just based on laboratory studies, not based on clinical assessment, not based on age, not based on any other information? This is an image from the hepatitis C guidelines, which are co-sponsored by the American Association for the Study of Liver Diseases and the Infectious Diseases Society of America. And this is the CDC recommended testing sequence. If you are concerned about an adult patient, a pregnant person, or a pediatric patient, traditionally, the standard testing sequence is to start with a hepatitis C antibody test. If that test is non-reactive, if there is no interaction between that person's body fluid, in most cases plasma, serum, or blood, and the underlying antibody test, if there's no antibody detected, typically the standard sequence stops. If an antibody is detected or is reactive, we suspect that there may have been immune activation to hepatitis C at some point, either in the past or currently. And that typically leads on to a confirmatory test or a hepatitis C RNA test. If that is not detected, we do not identify any current hepatitis C infection, and additional testing may be appropriate in select scenarios. But if it is detected, that's indicative of current hepatitis C infection, and that is an impetus for linkage to care. This is the basic framework of this two-step testing. What we're going to get into now is who, what populations, and also some variations to that. Next slide, please. This is an image from some of the draft CDC recommendations for hepatitis C testing in perinatally exposed infants and children. But I want you to focus on the graph because this is one of the most up-to-date CDC-sponsored graphs as it pertains to the changes that we are seeing across the United States related to hepatitis C. We often have had the best insight into the changes in the hepatitis C epidemic based on the number of new cases identified or acute hepatitis C cases. And what you can see is that over the past decade, particularly between around 2009 and 2020, a consistent incline across different age groups. And we'll talk a little bit more about why, but I think what this signals is something that many people on this call already recognize, is that hepatitis C has not been a stable, static epidemic. It's rather been one that has been growing. And in different demographics and in different regions, it's affected populations differently. Next slide. This is an image looking at the distribution of newly reported chronic hepatitis C cases, both by sex and age across the United States as of 2020. And what's interesting about this is that you can see two distinct peaks or humps or bumps, however you want to view this or reference it. But what you can see is that this is what we would call in a statistical term as a bimodal distribution. There are two primary areas that we see. Older patients, which we typically had historically associated with the so-called baby boomer cohort, or those born between 1945 and 1965, but actually a much younger age cohort than what historical models would have indicated. Next slide, please. This has been demonstrated consistently across different populations, but definitely here within the state of Tennessee. This shrinks the range up to actually expands the range from 2020 to 2016 to 2020. And this is just for Tennessee data. And what you see again is this bimodal distribution of younger adults and older adults being the most common populations with a confirmed and or probable case of hepatitis C. Can move on to the next slide. Because of these shifting dynamics, Historically, we thought about screening for hepatitis C as one that was focused on really initially risk factors. But in the early 2010s, a shift is saying, well, we should not only screen people with risk factors, but we should actually screen older adults, those in the baby boomer cohort between 1945 and 1965. But that's actually no longer part of the U.S. Preventive Service Task Force or CDC recommendation. Next slide. Instead, we actually now are at the point where the U.S. Preventive Service Task Force, as of March of 2020, which was buried right in the midst of something that I think a lot of other people were paying attention to, which was the onset of the COVID pandemic in the United States. At the same time that we started seeing the first cases of COVID throughout the U.S., this guideline came out that recommended universal screening of all adults age 18 to 79, regardless of risk factors. And that was really because we had actually identified more cases across different settings, and that universal screening would be a more effective public health intervention to identify appropriate populations. Next slide, please. That's important to highlight. That really means that all adults 18 and up really have an indication for hepatitis C testing. And what you can see there on the right is the CDC recommendations for hepatitis C screening among adults, which is a flyer that's available both on the CDC website and also through some of the links in the Project ECHO program. Just a little plug there to go to the chat window and to go to the Project ECHO page for the TDH team, which has a lot of great resources. This makes it really easy to operationalize that we should be screening everybody, regardless of risk factors. Also, very importantly, within CDC recommendations, is that all pregnant women or pregnant persons during each pregnancy should be tested or screened for hepatitis C. What that really means is that this testing hour has now expanded not only to universal adults, but when we're thinking about pregnant persons, we should also think about testing in that context. This does not mean that we shouldn't test people who have additional recognized conditions, exposures, or if people have specific requests. In fact, we actually need to do additional testing, not just one-time lifetime testing, but additional testing in select populations. Next slide. When we think about risk factors for screening, this goes beyond simple age or universal screening or other demographic indications such as pregnancy that would say, well, we should test this person. There are definitely certain exposures or behaviors or other conditions that are associated with hepatitis C infection. So if you are caring or part of a team caring for an individual, whether it be a client or a patient who has specific risk behaviors, risk exposures, or other conditions, hepatitis C testing may be additionally indicated. That includes people who have currently or ever injected drugs, people who currently or have past used intranasal drugs, men who have sex with men, people who have been on hemodialysis, those who have had percutaneous or parenteral exposures in unregulated settings, those with healthcare occupational exposures, children born to hepatitis C infected women, which we'll come back to in just a couple of minutes, prior clotting or a factor concentrate administered prior to 1987, or blood transfusion prior to 1992, or those who've been incarcerated. Additionally, medical conditions including HIV, someone who is sexually active about to start PrEP, people with unexplained chronic liver disease, or people undergoing solid organ recipient transplant, or those who are donating a solid organ, are all individuals who additionally should be considered for either initial or repeat hepatitis C testing. Next slide, please. Probably one of the most common questions I get as an infectious disease doctor, or when I assist with different education programming, is like, oh yeah, Cody, we get it. One-time lifetime screening, we should screen everybody, that's fine. But how often do you repeat screening, and who do you consider repeat screening for? And I consider repeat hepatitis C testing in a variety of settings. The first thing to highlight is that I mentioned that first algorithm where typically you start with an antibody and then you move on to an RNA test. There is a scenario where patients may have recently been exposed to hepatitis C and yet may have not mounted a sufficient antibody response to be captured on that traditional algorithm. So if you have a patient who has a recent risk exposure, particularly people with symptoms and or elevated liver function tests on laboratory profile, you might suspect an acute hepatitis C infection. And in that case, you may choose to directly send a hepatitis C RNA test. In addition, patients who have ongoing or high-risk exposures may warrant additional hepatitis C testing. And this table is again from the hepatitis C guidelines. And what it really identifies is that periodic repeat hepatitis C screening, which is the fourth line below, are appropriate for those with activity, exposure to conditions of circumstance associated with increased risk. Annual testing is recommended for all persons who inject drugs, for HIV-infected men who have unprotected sex with men and men who have sex with men taking pre-exposure prophylaxis. What this really identifies are populations who demographically and from behavioral standpoint are at higher risk for acquiring hepatitis C, and prior testing may be inadequate to capture future risk behavior-based activity. Next slide. So I think what's really exciting about this TDH echo is not just its focus on hepatitis C, and particularly among adult populations, but the commitment from TDH right up front to focus on persons who are pregnant and the potential of vertical transmission from a person who's pregnant to a child, as well as doing a better job as a state and as a region for capturing pediatric infection and also linking pediatric cases of hepatitis C to appropriate follow-up testing and treatments. And so this, I think, is what separates this ECHO program apart. And so we really want to encourage you, people in the community and other groups, if you're engaged with a group of clients or populations that could benefit from this information, particularly in the pediatric or in the obstetric realm, we want to help and engage those groups of providers and teams as well. Next slide. This is an area that's actually changing. So I'm going to present you some information of what the standard is today, but also show you a little bit more information about what we think is coming down the pipe. Again, the table from the left is from the hepatitis C guidelines, and it basically states that all children born hepatitis C infected women should be tested for hepatitis C infection, usually an antibody test at or after 18 months, that we shouldn't do a bunch of hepatitis C RNA testing repeatedly before 18 months, and those who have a positive antibody after 18 months should be tested with an RNA test to confirm whether they're actively infected. It's also important to highlight that if siblings are present of an individual who's been identified as having vertically acquired hepatitis C, those siblings should also be tested unless it's otherwise clearly documented that they've been tested and cleared of active infection. I mentioned the role of hepatitis C RNA testing here because it's been controversial. Historically, there's been concerns about when do you do it? When is it going to be accurate? How is this costly? This is a more expensive test than antibody testing. And how is that going to make a difference in clinical decision-making? Some people in public health have pushed for earlier tests with RNA testing to ensure that we capture those pediatric populations, whereas other groups have argued that really RNA testing doesn't change your treatment algorithm until you actually get to the point where you could treat that child. And so later testing is reasonable. The current guidelines panel currently recommends considering RNA testing as early as 2 months of age. And again, they repeat that there's no value in repetitive testing prior to 18 months. I'm emphasizing that this is the current, but there's a lot of discussion and there are some draft recommendations that are changing. Let's move to the next slide. If you go to either Tennessee.gov and the link to the CDC recommendations, essentially, if a child is 2 months to 18 months of age, if you choose to test, you would order a hepatitis C virus RNA test. That's going to give you the best commentary of what's actively occurring in that child. At 18 months of age or older, you could rely on the antibody test, and if positive at that point, you could move on to the RNA test. But there's a lack of consistency and clarity about how different programs, different clinics, or different groups approach. Next slide. This is what I think is really exciting is actually I've mentioned this draft CDC recommendation that has been open for public comment and is anticipated to be released officially later in 2023. And this is a algorithm that has been presented there. I'm going to pause here for a moment because this is a change as far as what's been officially recommended for perinatally exposed infants and children. One thing I should note right up front, I think something that is evident and obvious to a lot of people on this call, but women or persons who are pregnant who deliver, that's a very busy and complicated time of life. Follow-up is inconsistent at that point for both the individual who is pregnant as well as sometimes for the child. And for a variety of factors, sometimes that child who's perinatally exposed isn't consistently followed over the next 18 months. And that information about the pregnant person and that connection to the child often is lost over time. So there's been a lot of public health push to try to do earlier testing. And what the draft recommendations have proposed is that nucleic acid testing or NAT testing for a hepatitis C RNA test can be done as early if is age 2 to 6 months. If the RNA is detected, that's evidence of current hepatitis C infection and ongoing linkage to care and monitoring should be done. However, importantly, if hepatitis C RNA testing is not detected and that 2 to 6 month range. No further follow-up is necessary. And that's really important because it streamlines and it potentially makes the capture and follow-up for these individuals much easier from a public health and also from a clinical context. The historical algorithm of using an antibody test at age 18 months or older is still here. If it's non-reactive at 18 months, no further testing is necessary. And if it's reactive, then reflex or subsequent testing with RNA to determine active versus no infection is still appropriate and reasonable. But that left side of the algorithm is particularly important as we try to help both people who have recently delivered a child who's been exposed to hepatitis C and monitoring of that child to ensure they get appropriate follow-up and care. We can move to this last slide. I highlight this slide for say that definitely welcome questions from the audience about screening and testing. Those can be submitted either in the chat box or by raising your hands, and Mia will help us, or Lindsay will help us navigate that. I also would certainly welcome that if we have more discussions about our pediatric screening cases. I definitely will lean on my colleague, Dr. Farrell Cruz, to help in that regard. But again, it's my honor to be part of this team and to present today. And so happy to answer any of your questions.